is Darbey. I'm a genetic counselor and medical science liaison at Natera. I'm happy to be presenting on behalf of my co-authors Dinah Clark, Dr. Fang Fang, and Dr. Jing Zi, our poster entitled APOL1 Genotypes in Patients with Chronic Kidney Disease. This poster was presented at the American Society of Nephrology Kidney Week 2021. And a brief overview of the poster as it was presented at the conference is here. I'll go through section by section and provide a brief overview. Inheritance of APOL1 G1 and G2 risk alleles under a recessive model is associated with an increased risk of chronic kidney disease in African Americans and other individuals with recent African ancestry. A diagnosis of focal segmental glomerulosclerosis is 5 times more likely in individuals with 2 high-risk alleles, and hypertension attributed end-stage kidney disease is 4 times more likely. The precise mechanism of APOL1 related disease has not been fully elucidated, but it is well established that co-occurrence of 2 APOL1 risk alleles is not completely penetrant. Additional genetic and or environmental factors are necessary for an individual to develop CKD. It's been reported that approximately 10% of individuals with CKD have causal genetic variants when tested on exome-based next-generation sequencing, but there are few reports examining co-occurrence of APOL1 high-risk genotype alongside other monogenic causes of CKD. So in this study, we examined co-occurrence of the APOL1 high-risk genotype plus a second or additional genetic diagnosis, which we term APOL1+. And this is using a broad NGS panel of genes associated with CKD. So clinical samples were submitted for the evaluation of the genetic etiology of CKD in pediatric and adult patients. These samples were analyzed via a next-generation sequencing panel of over 380 genes associated with isolated and syndromic forms of chronic kidney disease. For genes other than APOL1, positive results were defined as having 1 pathogenic or 1 likely pathogenic variant in an autosomal dominant or X-linked gene, or 2 pathogenic or likely pathogenic variants in an autosomal recessive gene. Cases with 2 APOL1 risk alleles, either G1 G1, G1 G2, or G2 G2, were also reported as positive. In this cohort, a total of 1,816 positive findings were identified in 1,600 different tested individuals. So these positives spanned 124 unique panel genes, the top 40 of which are included in Figure 1A. APOL1 high-risk genotypes comprised 24% of all positive findings. The other genes in which frequent positive findings were identified included PKD1 and 2, associated with autosomal dominant polycystic kidney disease, and collagen 4A3, 4A4, and 4A5, associated with Alport syndrome and other collagen 4A related conditions. Among the positive cases, 7% had greater than 1 positive result. So 115 patients had a dual genetic diagnosis, and 4 patients actually had a triple genetic diagnosis observed on the panel. And this is depicted in Figure 1B. Out of all cases with multiple diagnoses, the APOL1 high-risk genotype was present in about half. This amounts to 3.5% of all positive cases and 14% of all APOL1 positive cases. Among those APOL1 plus cases with a secondary or third finding, the secondary findings were most commonly observed in the collagen 4A3, 4A4, and 4A5 genes, the TTR gene, which is associated with transthyretin amyloidosis, and the PKD1 and 2 genes. So all APOL1 positive cases are represented here in Figure 2. We appreciate that genetic testing in patients with chronic kidney disease can lead to improved clinical management, more informed reproductive risk counseling, and identification of at-risk family members. And the current study demonstrates that dual genetic diagnoses, which may potentially influence presentation and therefore be more difficult to identify clinically, these dual diagnoses are really not uncommon in the CKD population. In this particular cohort, dual diagnoses comprise 7% of all positive genetic testing results. And while we understand that the APOL1 high-risk genotype confers an increased risk for various types of CKD in individuals who carry that genotype, we don't know much about how the APOL1 high-risk genotype may influence phenotype in patients with other underlying genetic forms of CKD. In this study, a significant portion of the APOL1 plus cases included pathogenic or likely pathogenic variations in the collagen 4A genes. And these cases are of particular interest given that both APOL1 and the collagen 4 genes are associated with glomerular disease and are both among the most common positive genes identified in CKD patients undergoing genetic testing. So future studies are certainly needed to better understand how these multiple genetic diagnoses, including the APOL1 high-risk genotype, may impact presentation and progression. And it's certainly our hope that increased access to genetic testing in the CKD population through the utilization of NGS panels will hopefully improve our ability to diagnose and manage these patients.